So today's webinar is COVID-19, Lessons from the Front Line, the Acute Respiratory Clinic. The purpose of the webinar was to address a gap in outpatient evidence-based tools where we don't currently have tools for clinical assessment in the non-ER setting, outpatient treatments, triage and disposition, and even setting up a new clinic like this. So we wanted to share our experience as we've gained experience with nearly 200 patients in the respiratory clinic. We want to share our experiences and promote dialogue. It's not intended to be Emory specific. Our target audience is outpatient providers managing COVID-19 in a clinic setting. It's not a comprehensive literature review or a practice guideline, nor is it a specific workflow discussion. If you're watching live, I'm going to try a Zoom poll at the end to get your feedback, and so please stay on at the end. The speakers for today are Jennifer Zrailoff. She is the interim medical director here at the CV Internal Medicine Clinic and the medical director of the Acute Respiratory Clinic. Jason Higdon, whose role was setting up some of the clinical processes, including direct admissions and post-discharge handouts and care plans for ARC patients. Dr. Henry Wu, who was seeing patients in the Travel Well Clinic before we were in the Acute Respiratory Clinic, and he is seeing patients here now. And then myself, if there's time at the end, will just give brief thoughts as a member of the clinic team, a person who has seen patients in ARC. We have no conflicts of interest, and with that, I will turn over to our first speaker, Jennifer Zrailoff.
All right, hi everybody. I am mainly going to talk about how we opened up the clinic in quite a quick fashion. So first of all, we decided that there was a big gap between our emergency care that our patients definitely needed in hospitalization and no care at all. You know, we as primary care doctors are used to delivering ambulatory care, and we did not really have a venue for in-person ambulatory care that honored infection control guidelines. So that was the purpose of our acute respiratory clinic, was to provide a clinical site for our infectious patients or even potentially infectious patients who could not get adequate care virtually or also did not meet the acuity level of an emergency department. So the first thing we had to do was get all the right players in the room. Like I mentioned, this clinic was opened within 1 week. So what we learned was that we definitely needed executive sponsorship. Our executives are able to shut down a lab like we had to do and change parking for all of our executives. It changed the traffic flow through our whole clinic building and even enable redeployment of staff and equipment. So without their leadership, none of the benefits of the clinic could have been achieved. What I also learned opening this clinic was that a project manager was the most vital in keeping all the momentum and organization going. She provided all the documentation of our meetings, set the agenda, even led our meetings, and has created a living document of SOPs, which is highly needed. Most people are used to an ambulatory setting having a nursing leader, administrative leader, and a clinical leader. So of course we still needed those in our ambulatory setting. Our clinical leads were more unique in the fact that this was a collaboration with infectious disease and general medicine. Henry Wu is our infectious disease lead, and he has been very instrumental in helping us deliver ambulatory care safely. He was our local liaison for infection control, but we did work with our clinic infection control lead. She did walk us through all the different processes for cleaning our rooms and setting up appropriate PPE divided by different roles in the clinical setting. We also had to work with a lot of ancillary support, such as our lab, radiology, security, and even facilities, as far as how often they would be able to clean or would they be able to clean a bathroom urgently, and that sort of thing. And I like to call it the Redeployment Palooza. So we worked with all these different settings, and then we took people from all sorts of different areas within our healthcare system to make this clinic work. We were particularly interested in recruiting surgical techs because they by the nature of their job or are more intentional as far as what they touch, and therefore we thought they would be good in the clinic setting where we were trying to minimize contacts with things. Also, all of our ambulatory surgeries had been put on hold, so they were also in need of a job, so we found that to be a good fit. But we also received medical assistance from the system. Our registered nurses were vital in opening this clinic. We received 2 registered nurses from our travel well clinic that were very knowledgeable and really helped all the other registered nurses. Our clinic is quite rich in that staffing, in the fact that we have 5 registered nurses for 3 providers. We also got administrative assistance. We got attendings and fellows from infectious disease, MDs and APPs from throughout our GIM sites. We got our rad tech as well as a phlebotomist to join our clinic. We did need to define all these processes. We had a brand new clinic that had a lot of different issues in place, such as who would be scheduling for this clinic. It wasn't a clinic that we could just take all the staff and plop into a new role. So what were the scheduling guidelines? Would we be scheduling just on site, or would we be using our central scheduling, and would they need guidance for this? We also had to come up with a whole new route for patient arrival. These patients, because they were potentially infectious, could not use valet, for example. We didn't want them to park in a regular parking deck and go through 2 different elevators to get to our clinic. So we had to work through a novel entryway for patients to come in directly to our clinic. We also just had to work through all the clinical flow that you would for any new clinic, including sample collection and ordering, EKG. That was quite a tricky one, considering we did want to keep our EKG machines clean and also wanted to preserve PPE. So all of our providers had to relearn how to set up EKGs in the room. We also had to figure out IV hydration and infection prevention in every process that we delivered. We also had to figure out post-visit care. So patient education was very important. How we would give after-hours medical advice, or even during clinic hours medical advice, and who would be giving that, what phone number would they call? And then also how would we track labs that were ordered with so many different staff members coming and going. What I learned was that the must-haves were an SOP. We have a very long, very detailed SOP for every process that we developed, and it is on box and shareable, and many people have contributed to its editing. It was also really important to develop staff training. Our nurse leads definitely put in a lot of time to make sure our nurses knew exactly what to do in all these new processes that were delivered. We also needed provider training, which was primarily them shadowing. We found that to be something that was familiar for providers as far as training. We are used to learning by following and shadowing. And then very importantly were clinical guidelines. Since this was a new disease that no one had really treated before, it was important to have the latest clinical guidelines. And these were supplied by Dr. O'Keefe. We also needed to figure out how we fit into this larger healthcare system. So we had sort of how we interfaced as far as people coming to our clinic, and then also how we interfaced with people sending patients to other sites. So we had to figure out how we would work with our specialists. We have arranged for us to be able to have echoes done here in our clinic. Ophthalmology has also set up equipment here in our clinic to see their potentially infectious patients. Radiology has been amazing as far as helping us get the x-rays in sight in our clinic suite and also helping us read all the x-rays. We have received a lot of our patients from our virtual outpatient management clinic, and working through defining or attempting to define appropriate escalation protocols was part of our work. Also working with our care coordination team, which is in charge of hospital discharges. Oftentimes, patients who were hospitalized with COVID don't have clear follow-up plans. Either they never had a PCP or their PCP is not yet comfortable with potentially infectious patients. Also, we have an avenue for emergency department patients to follow up with us, as well as PCPs can directly send patients to us. We needed to work out sending patients to the emergency department and our processes for infection control with that. We also worked out the processes for direct admit for the hospital, and Dr. Higdon set up criteria with our hospitalist service that both sides would feel comfortable with. Then we also send patients to our virtual outpatient management clinic for further follow-up, as well as sending patients to our PCPs. So we did have some unexpected issues. When you take people out of their clinical setting and put them in new roles, and even roles no one had ever heard of, such as air traffic controller, which is one of the roles of our nurses, you have new roles and people who you've never met before, and they're all wearing masks, makes confusion very likely. And working through processes to decrease confusion, and even wearing name tags that tell what role you're going to be playing that day have been helpful. We were also sort of caught off guard by how many patients were needing help with transportation. It's a little more difficult to tell a patient who is diagnosed with COVID to take a lift to come and visit us. So we worked through our care coordinators and social services to help with transportation. Also, I believe there to be a higher density of patients needing interpreters in our clinic. I suspect one of the reasons is it's much more difficult to deliver care virtually when you are missing that direct communication with a patient. And I believe that our virtual caregivers found it more important to refer a patient to the ambulatory clinic here because they couldn't really communicate well. We also didn't expect that our staff would be redeployed before we were ready to close our site. So now that our ambulatory surgery sites have started to open and schedule, obviously those staff members have been recalled to their original work site where we still need them in our site. Also, we had to think through our weekend processes. Our acute respiratory clinic is open 7 days a week, but we had to think through the fact that facilities and security might not have those same weekend hours. We've also had to really define what is possibly infectious. It is quite a gray zone as far as either following the guidelines that we set forth for people to go back to work, which is 7 days after symptoms started and 3 days afebrile are the CDC guidelines. However, that doesn't feel right to most providers as far as feeling willing to see these patients with continued respiratory symptoms face-to-face in their own clinics. Even sometimes we wonder about a patient that might be 5 weeks out that maybe is having a reactivation, or there's always that specter of false negative results. If a patient has a test that's negative for COVID, we know that false negatives exist, and how often do they exist can be really difficult for a physician that is not in PPE and has the responsibility for protecting their staff to bring those patients in, even though they might not necessarily be clearly infectious. Also, another unexpected issue was our variations among our providers as far as how they might treat a patient who they find important to bring in and evaluate face-to-face versus who is important to treat virtually, as well as expectations as far as workups done in the acute respiratory clinic, such as a provider might think in the clinic that an x-ray is not needed, but the PCP who sent them there was requesting it. So working through those variations was an unexpected issue as well. So after 3 weeks, we have seen 176 patients through 184 visits. 4 patients were directly admitted to the hospitalist service, and 14 patients were transferred to the emergency department, 12 of which were admitted. So I like to think that we kept about 160 patients out of the emergency department by way of having an ambulatory setting for potentially infectious patients. And I like to say that many hands make light work. And there were many, many people involved with the success of the Acute Respiratory Clinic. This is a list of those that I could remember, but I'm confident I have forgotten some.
Thanks, Jenny. So she talked a lot about what it took to get our clinic started and keep it running. I was going to talk a little bit about my experience providing care outside of the hospital, but in person. I'll talk about 3 main areas. The first is just high-level reflections after 3 to 4 weeks in the acute respiratory clinic. Some takeaways from the patients that I've seen and experienced working with others during this time. So from the reflections, I would say one is it feels really good to provide in-person care again. In the pandemic, I think we've all gotten probably overly familiar with providing care via telephone and via video platforms like Zoom. So even though we're separated from the patients by PPE, it's nice to be in the room and to provide hands-on care again. It reminded me of what it feels like to be a doctor. I think the other was this feeling of a provider identity crisis. So my normal role is a primary care doctor, and I think the care that we provide in ARC is definitely much more focused and almost feels like a consultant where in my mind, the primary task is to figure out where is it appropriate to continue this patient's care after the visit. Can they go home with virtual follow-up, or do they need to go to acute care like the emergency room or hospital admission? And I think it was also difficult because while we had a wealth of resources, the resources were still significantly limited compared to what we would normally have in an outpatient setting. And so those old habits of wanting to address everything and answer all of the questions had to kind of be quelled a little bit, and making sure that we're addressing the main issue at hand and making sure that we understand what we can do to help the patient feel better, but also making sure that their disposition is a safe disposition based on how they're doing. The other thing that's been hard to come to terms with, I think, is just walking into a room knowing that your personal experience is significantly less compared to when you would normally walk into a room and treat a patient for the wide variety of diseases that you're used to dealing with, and that you don't really have a good evidence base to go to. A lot of the evidence that's available right now is really in the sicker population and patients that are hospitalized or are cared for through the ER. And so part of this is really just doing the best that you can to take care of the patient. And that fed in, I think, to the last point, which is there's a high level of anxiety. I'll start by talking about the level of anxiety with providers. And it's hard when you're used to being able to rely on your instincts for sick and not sick, and you're looking at a disease that we don't have a good sense of what is kind of the typical course for a person compared to the spectrum of everything that you see. And sometimes it's very clear that somebody is sick, but some of the people that I think my instincts would have told me not sick, I would see them not do well in the near future. And so that had been very difficult. And I think also a high level of anxiety for the patients and providers, because everything we see in the news media says that everything is bad, bad, bad. And so patients are worried about that happening to them. And as your doctor, you're worried about missing that could happen to them and maybe triaging them to the wrong place. So shifting gears to talk a little bit more about the patients that we've seen. So I looked back at the patients that I've seen over the past 3 or 4 weeks, and out of those, 40% were COVID positive. None of these patients were hypoxic at rest. 2 were hypoxic with walking. And interestingly, both of those patients were late in their course, about 5 to 6 weeks after symptom onset, and both of them ended up having a secondary pneumonia on their imaging. However, the majority of I would say many patients out of this 40% have had prolonged lower respiratory symptoms. So persistent cough, but also persistent shortness of breath and persistent chest tightness, which certainly can be worrisome or disheartening for them, and sometimes confusing to figure out the best way to manage that as the provider. And then some patients with iatrogenic problems. So we're trying to help them, but we end up giving them medicines that cause other issues. The larger cohort has been about 60% of patients that were suspected COVID, but ultimately tested negative. And this was a reminder that common things are still common. Patients still have URIs. This is allergy season in Atlanta, and it's been particularly bad. So patients come in with allergy symptoms and or asthma symptoms. Patients coming in with decompensated heart failure. Patients with community-acquired pneumonia. And as Dr. Zriloff was talking about, there's also this kind of specter of false negatives, and we don't, or at least I don't have an understanding of how common is that in the outpatient setting, especially for patients that come in that have a typical flu-like viral prodrome, but at a time where we're seeing no flu circulating in the Atlanta community. And then patients that had quote unquote classic COVID symptoms, and including abnormal chest x-rays consistent with a viral pneumonia, but testing negative. Now, this was more typical earlier on when testing was more limited, and so patients were getting tested later in their course. So it may just been at that point that the PCR was negative because they were far enough along. And then lastly, I'll just touch on working with others. So as Dr. Zriloff said, there were many players involved. And it's been nice working side by side with other providers in ARC because we bring different things to the patient care experience. And it's been nice to have a sounding board in a time where your experience and instincts may not be enough to provide the care that's needed. It's also been great to work with staff from other roles and to see processes that come up that aren't working like we want and figuring out how to fix those on the fly. And as Dr. Zriloff mentioned, we work with hospital medicine to come up with some standard criteria on patients that would be reasonable for hospital admission, and to also have common ground for identifying patients that were too sick for direct admission, so that when the time came to direct admit patients, the process was more streamlined. And just an aside on radiology, radiologists have never been more interested in knowing about the patients that we're taking care of, especially when I call them with an abnormal x-ray to get their opinion, asking questions about how the patient presented, what they look like, what they sound like, what we're going to do for them. So that's been kind of interesting as well.
So in anticipating time, I think Dr. Wu will speak to us next. He takes about, I think, 8 minutes for his slides. And if you're able to stay, I would encourage you to. And then we'll have a brief questionnaire at the end if you're able to stay on for that. And we'll move on to Dr. Wu.
Next slide. Hello, Henry Wu here. So just some ID considerations. First, for about design, as you might notice, COVID-19 has a wide range of presentations and complications, ranging from asymptomatic to our sick ICU patients. Therefore, the differential diagnosis is broad. Again, potential for a risk of severe complications and co-infections. And therefore, as you already heard, a multidisciplinary team as well as access to various testing modalities is critical. Next slide. Another interesting aspect is that we've all seen or heard about cases that unpredictably declined. So rapid, unpredictable onset of complications. Therefore, we felt strongly that there is a need to be able to address these needs urgently, as well as access to higher levels of care. And that's, again, why we're open 7 days a week and are connected to the hospital. Next slide. Finally, here, obviously know there are many infection control issues, highly contagious disease, risk to healthcare workers and patients who may not have infection. Of course, PPE and infection prevention is key, but we're all working under the shadow of this ongoing limitations and supplies and need to conserve. So there, as is true across the whole health system, a lot of this is is shaping the way we design processes. Next slide. So this is sort of more of a visual depiction of what Jenny has already shown in terms of coordination of care across the Emory system. Next slide. So some PPE infection prevention sort of key points. As you have, I'm sure you've noticed, guidance seems to change every few weeks, both from CDC and even with our own health system as we learn new things. I think we're getting closer and closer to, you know, get better and better each time. But a couple guidance themes are consistent. One key thing is source control. So again, making sure the patient who may be ill with it is masked as soon as possible with controlled entry and exit. On the staff side, protecting our staff is obviously very important. We are following universal face masking, minimizing you know, contact with patients, maintaining distance unless we are doing an exam or performing a procedure. For those of us in direct contact, we are following the usual guidance from our health system and in N95, masks, face shields, and gowns. There's fairly strict protocols for cleaning the equipment and exam rooms. And again, to do this takes a lot of training, drills, and process improvement. Even if you've been experienced with a PPE, using it in this setting may not be very familiar. Next slide. Some clinical pointers here. We get a lot of questions about patients who test positive over and over again. This is some recent data out of China showing that as many as half of patients with COVID-19 will still be positive by RT-PCR week 3 into illness, and some may be positive as far out as 6 weeks. And so it's not surprising that many patients have repeat positive tests, which limits its clinical utility. Which raises the question, though, are these necessarily infectious? Next slide. We don't think so. We think a lot of this persistent positivity does not reflect infectious virus. Here's some other data. This is modeled data of how long a patient or what period a patient is infectious around the time of symptom onset. The big caveat is that this is based on observed transmission pairs and model data. So, but at the same time, this is probably our best sort of summary of what we think is going on. The bad news is that patients are highly infectious before symptoms begin. But it does appear on the good side in that the infectiousness probably drops significantly after a few days out. Next slide. So you all know that clinical CDC criteria for ending isolation. I think we all agree that it may not be 100% perfect. Therefore, you might have noticed the extension of some of these periods, particularly for healthcare workers. And again, just in case we're not catching everybody, face masking is very important for both patients or healthcare workers coming back into society. Next slide. Co-infection is always a concern. It's well described, COVID-2 with influenza. A lot of it, of course, depends on what else is circulating. Next slide. This is some data from Georgia on influenza-like illness by week this season. And you can, these are broken down by age groups, but you can see there are multiple peaks. The most recent peak of flu-like illness is going to be in the sort of late March, early April period. So, but at the same time, next slide, if you look at the percent positive flu tests in flu surveillance, that drops, you know, very low during that same period. So what I think that last bump represents is a primarily driven by COVID illnesses. So, as was already mentioned, we're not seeing much flu anymore. Early on, we were seeing a bit of more flu and potentially even treating folks empirically with Tamiflu at times while waiting for results. Next slide. Serology is a common question now. Unfortunately, I feel like there's very limited clinical utility. It certainly is not useful for diagnosing acute infections, and there's still a lot to be learned about these tests, you know, and not only their performance parameters, but whether or not even a positive serology equals protective immunity. So just stay tuned for now. Very useful epidemiologic tool, as well as potentially a way to diagnose somebody who had an illness in the past and might be a indicator of what they had, but otherwise limited clinical utility. Next slide. Final thoughts. You know, as you might have heard, this is a lot of learning on the fly. So we're all doing our best under circumstances. Above all else, Obviously, we need to be safe. I am confident that the procedures we've developed do protect our patients and staff. We have all done plenty of empiric treatment and aggressive testing, a bit more than we may have in normal circumstances, but given the situations we're faced, sometimes this is the best way to take care of your patients. Unfortunately, I don't think COVID-19 is going away anytime soon, and we will have to learn to do things differently. I don't think ARC is necessarily going to exist in its same form in the future, but it is a bridge to whatever our new normal is. I do think it's not all bad, considering that there's always going to be risk of other infectious diseases like flu, TB, and measles, so some of these procedures will help protect us against that. So, as most important, be prepared to adapt as the situation evolves, and it seems every week we're making another change. Thank you very much.
So I don't know if folks can see the poll on their screens.
Yep, it popped up.
So if you have time, please fill it out. Just let us know if this is useful. Any suggested changes. Thanks everybody for attending, and especially thank you to the speakers today.